There's a silent pandemic unfolding all across India. It's a crisis that's threatening the very foundation of modern medicine. Today, we're going to break down this urgent threat, antimicrobial resistance.
And look, this isn't some far-off medical theory. According to a senior ICMR scientist, Dr. Kamini Walia, this is a silent, nationwide public health crisis that is already here, and it's chipping away at our most essential medicines.
To really get a sense of the scale, just look at this number. In a single year, that's how many people in India are estimated to have died from infections that our drugs just couldn't treat anymore. It's an absolutely staggering figure for a crisis that, for most of us, has been completely invisible.
So how on earth did we get to such a devastating number? Well, according to Dr. Walia, it all starts with a very simple, very common habit. A habit so ingrained in us, we barely even think twice about it, reaching for an antibiotic for a common cold. So let's dig into this antibiotic habit of ours. We're going to explore exactly how this quick fix is creating a really dangerous long-term problem and get to the bottom of our relationship with these powerful medicines.
You see, at the heart of this whole problem is a pretty fundamental misunderstanding. Antibiotics are built to kill bacteria. That's it. They do absolutely nothing against viruses. So they are completely useless against things like the common cold or the flu. Every single time we take one for a virus, we get all of the risk and literally none of the benefit.
And this basic misunderstanding has led to a whole set of risky habits. Things like taking leftover pills from the medicine cabinet, asking a pharmacist for a quick fix for the flu, or even doctors prescribing antibiotics just in case, without even knowing if it's a bacterial infection. So what happens with all this overuse? Well, we're basically putting immense evolutionary pressure on bacteria. We're forcing them to adapt or die. And the ones that survive? They develop these powerful defenses, turning into what we call superbugs. Then they pass those defenses to the next generation, creating whole armies of bacteria that our best medicines just can't kill anymore.
And this isn't some theoretical problem for the future. No way. It's happening right now. Let's take a look at the real-world impact when our cures just stop working.
We're talking about illnesses that we used to manage so easily. Things like typhoid, pneumonia, even a common urinary tract infection. These community-acquired infections are becoming more and more resistant to standard treatments, turning what should be a routine sickness into a complicated and sometimes dangerous ordeal. And if you think that's bad, the situation inside our hospitals is even more alarming. An ongoing study by the ICMR is finding that 1 out of every 10 patients admitted with an infection is resistant to our last resort antibiotics. These are the heavy hitters, the drugs doctors use when absolutely nothing else works, and they're already starting to fail.
And to make matters even worse, Dr. Walia warns that the pipeline for new antibiotics is running dangerously dry. We're in this race against bacterial evolution, and frankly, we're falling behind. We're using up the drugs we have with no real replacements on the horizon.
Okay, I know that all sounds pretty grim, but there is hope. The battle is not lost. In this next section, let's explore the actual strategies that are already making a difference and how we can start to turn this tide.
So you might be thinking, if these drugs are causing so much harm, should we just ban them? It seems like a simple solution, but the reality is way more complex.
The solution isn't about banning the tool. It's about learning how to use it right. Dr. Walia puts it perfectly with this analogy. We have knives at home, right? But we use them to cut fruits and vegetables, not to hurt people. That's the core idea of antibiotic stewardship, using these powerful medicines responsibly and only for what they're actually meant for.
And this isn't just a nice idea. We have a real-world example. Over a decade ago, Kerala started a stewardship program. Now, what's really important is they didn't start with a ban. They started with step 1, educating doctors. Then came step 2, building public awareness. It was only after 10 years of that groundwork that they moved to step 3 and banned over-the-counter sales. It just goes to show that a patient, strategic approach is what really works. And get this, here's the really good news. Bacteria can actually lose their resistance. Back in the 90s, certain drugs just stopped working against typhoid. So doctors stopped using them. Now, years later, research is showing that those same old drugs are starting to work again in some areas. By easing the pressure, we actually give the medicine a chance to bounce back. How cool is that?
So as we look ahead, the fight definitely gets more complex, but at the same time, new frontiers in science are opening up. Let's explore that wider context and the challenges that are still out there. So where is all this resistance really coming from? Well, a fascinating ICMR study gives us a big clue. It found a significant overlap between the resistance genes they found in patients and the genes found right there in the hospital environment, on surfaces and equipment. This shows that our healthcare settings themselves can become hotspots for spreading these superbugs.
But here's the really surprising contrast. That same study found almost no overlap between resistance genes in humans and the ones from animal sources. Now, while antibiotic use in livestock is a big global concern, this suggests that here in India, the primary driver of resistance in humans seems to be our own behavior in human medicine.
Now, one of the biggest challenges we face is just getting a clear picture of what's happening. The ICMR's surveillance network is fantastic, but it's limited to just 25 major hospitals. This means the data often shows us the worst-case, highest resistance scenarios and isn't really representative of the whole country. We've got to widen that circle of data collection.
Looking forward, though, there's some really exciting research into alternatives. There's something called phage therapy, which uses viruses that actually hunt and kill bacteria. Monoclonal antibodies are another promising field. These are still in the early days, for sure, but they represent a new hope for a future that might go beyond our traditional antibiotics.
And so, we kind of end where we began. This entire crisis was built by millions of small individual decisions made every single day. Which leaves us with a final, really powerful question. If our daily habits helped create this problem, can our new, more informed choices actually become the cure?